Hello, everyone. Welcome to the RheumNow podcast. It's September 22nd, 2023. Today we have a special guest, good friend and world beater in RA and all things rheumatology, Dr. Michael Weinblatt from the Brigham. Hi, Mike. How are you?
Good, Jack. Thanks so much. Very kind introduction. Thank you.
It's well deserved. Michael's been very helpful in this past month on the website. He and Janet Pope were instrumental in planning this Hard Decisions in RA campaign, where we try to expand our thinking and our reporting on RA to get a lot of new views. That's why I've asked Mike to come on and help review the news and to review this past Tuesday Night Rheumatology, which was on Methotrexate decisions. I'll start by saying, Mike, that was an incredible hit. I mean, before we woke up the next morning, that broadcast, a 1 hour broadcast, had over 1,000 views on the different channels that we put it out to. So amazing, and thank you for doing that.
Well, methotrexate's an old drug, but it's probably as important a drug as we have for rheumatoid arthritis. Yeah. And we're always learning about the medicine. I mean, 40 years after, we did our trials, we're still learning about the drug. It's pretty amazing. And it's the background therapy, and the biologics have only enhanced the importance of methotrexate in the management of RA. I don't see it going away anytime soon.
I liked how you began that webinar, Tuesday Night Rheumatology. You said that that when I invite you back 10 years from now, we'll still be talking about methotrexate as the kingpin.
Yeah, other drug, the JAK inhibitors clearly beat methotrexate in the randomized trials. But even before we had oral surveillance and the change in label, I never thought that methotrexate would be replaced by any of our newer therapies because of the cost differential. I mean, it's really hard to spend $50,000-$60,000 on a therapy that's really good when methotrexate is really good in at least a third of patients in like a $2,000 a year cost, and elsewhere, maybe even less elsewhere. So, we got to learn how to use it. We got to learn how to use it better. We need to learn how to make sure we don't harm our patients. And when it's not working, we need to go to another treatment or add another treatment.
So I wanted to end with this, but since we're on the subject in this Tuesday Night Rheumatology webinar, the topic was methotrexate decisions. We got survey results from rheumatologists. We had a great panel, which was you and Grace Wright and Richard Conway and Joel Kremer. And we discussed a lot. It was just amazing at how many people showed up. So first question to you about that panel, which people can see on the website or on YouTube or on podcasts. Why do you think that we're still so enamored with methotrexate? Do you have a good reason for that?
Well, it's a complicated drug. Let's start with that. There are nuances in how to use it. I mean, I refer to methotrexate like prednisone in PMR. I mean, you're tweaking the molecule. And I think those of us that are successful with the drug have learned how to play with the molecule. It does have side effects. There are tolerability issues. And I think you just have to learn about the drug and learn how to monitor and learn how to reduce side effects. Because I must say, in my practice, I don't have 50% of patients stopping the drug because of toxicity issues. I mean, you got to play with it. And we're always learning about it. So, I think rheumatologists appreciate how important it is for our disease, rheumatoid arthritis, and want to learn how to use it better.
In that webinar, we reviewed a lot of information about folate dosing, methotrexate dosing, lung disease, monitoring, whatnot. Is there one big takeaway that you'd want to reinforce for the audience?
Yeah, two. Number one is I was really impressed by the consistency of response between Europe and the United States on using folic acid or leucovorin, but also on the lung disease. I mean, that was reassuring. Richard Conway's an expert in this area. And, Grace, Joel, and I all felt, we all had different views. But in the end, I think we all felt fairly comfortable in using methotrexate in the setting of not terrible underlying lung disease. And I think we were all consistent about monitoring. I mean, I think we all felt that you got to monitor these patients, and getting blood work 4 times a year is not the end of the world, and it can really protect our patients. And that's the goal. It's a good drug and make sure that it's used safely.
Yeah, the survey result that Mike's referring to is that both in the US and rest of the world, 20% of rheumatologists won't use methotrexate in ILD, but 80% will, sometimes with a lung doc or not. So yeah, I think it was surprising how unified we are in our thinking there.
So
All right, let's get into some of the reports this week. Mike, there's a conversation where I want to get your input on over and above my usual diatribe on these things, which I'm already on record as saying. So the first is basically a press release this week from UCB. They've been doing work on a dual IL-17 inhibitor, an AF inhibitor called bimekizumab. They got good data in psoriasis, good data in psoriatic arthritis. They're slated for a third quarter FDA approval or denial, but a third quarter FDA approval that didn't happen on time. And so they put out a press release saying that its application, its BLA, is still pending, and the FDA review is still ongoing, and there's no date for delivery. Earlier, or almost not quite a year ago, there was a delay at the FDA. They received a complete response letter, had something to do with manufacturing and whatnot. But what's your take on this non-decision, and B, what might be the role of yet another IL-17 inhibitor in this space?
well, let's do this. Let's talk about the role of another IL-17 inhibitor. I mean, it's going to be pretty hard to show that you're substantially better than the two we got. I mean, they're really good drugs for PSA, for the psoriasis aspect. On the joint disease, there's obviously a lot of opportunity because none of these drugs are superior in my mind on the joint aspect. But on the skin disease, boy, 17 blockade and 23 blockade are really remarkable.
Right.
To show you're better than the existing 17 inhibitors is going to be really, really difficult. And, I don't know that you need a third anti-IL-17 inhibitor that works about the same as everything else we got, unless you're able to show some subtle improvement, particularly if it shows improvement in the joint disease. From a side effect standpoint, it's going to be impossible to show you're better because their side effect, the two existing ones are really well tolerated unless you have IBD as an underlying process. So, UCB's got this is like Cimzia all over again. I mean, certolizumab pegol is a really good drug, but they were like fourth to market, and where do you place it? So,
I like that you brought that up because I was thinking the exact same thing. It's going to be hard for the third drug to market to show it's better because the results kind of look the same. The only way you can be better as third drug to market is be better at marketing. I mean, didn't that happen with adalimumab? Or do you think it's another reason why adalimumab really took off as well as it did? So
yeah.
infliximab and etanercept are on the market doing well. They're kingpins. They're killing it. And a third drug comes to market and ultimately takes over. Is that because of better marketing?
Well, I think with the case of adalimumab, they had a very favorable dosing regimen of every 2 weeks. Number one, that helped. And then the decision they made, it's not marketing, it's more sales, to go into a rebate program. I mean, what drove adalimumab wasn't our prescribing of the drug per se. What really drove it is when they set up rebates with the PBMs, where the ability for us to make a decision about which sub-Q anti-TNF therapy we would use was taken out of our hands. Because for many years, etanercept still remained the number one for many years, even after adalimumab was approved. And it really wasn't until they changed, when they went into this rebate program with the PBMs, that absolutely turned things upside down.
Right. So yeah, that's a closed door business negotiation deal. So
yeah,
I personally don't get too concerned about these delays and approvals because these are just basically more meetings that have to happen and more signatures. I guess the sinister mind might think there's something going on here. I personally don't view that. I don't know if you feel the same.
Yeah, it's really, without being down in the room, it's kind of like Hamilton. If you're not in the room, you're not in the room. I don't know what the FDA is thinking and why it's taking so long. I mean, maybe there's something in the package we don't know about, or maybe it's just the usual bureaucracy going through all of this. So I think until we know, we don't know. How's that?
Right. Well, speaking about more of what we don't know, the black box, it is a regulatory agency. The European Commission and the EMA approved just yesterday, its first tocilizumab IL-6 inhibitor biosimilar. The German company that makes it is Fresenius Kabi. They got a name for it called Tyene. Odd name for a drug, but that's what you get with drug names. So this is the first tocilizumab biosimilar. I think it's due to happen also in the U.S. sometime in the near future. It's going to have the same indications: RA, stills, poly-JIA, GCA, and CAR T cell cytokine release, and also COVID-19. I think this is a major advance, and is going to get us here more into, in the United States, more into biosimilar use, which I think is a good thing.
Well, I'm all in favor of biosimilars if they do what they promised they would do, which was to lower the cost for the consumer. And we certainly haven't seen that with adalimumab so far. And it took, what, 3 or 4 years to see some significant price reductions in the US with infliximab. And if there's not significant price reduction, then who cares? Because administering biosimilars, when we see what's going to happen with 7 or 8 adalimumab biosimilars, the amount of work that's going to be placed on the rheumatologist, it's not going to be insignificant.
No.
And unless there's a significant cost reduction for my patient, who cares? I'm delighted a biosimilar for IL-6 has been approved. It's going to help on the IV side if you're using tocilizumab IV, and sub-Q, I don't know yet. I mean, we'll have to see. So I wish we were Europe in that sense, where the prices have really dropped significantly with the biosimilars, and we just not seen it so far.
No, it's unfortunate. And of these 9 adalimumab biosimilars, I think it's 6 of them come in with a dual pricing schedule, a 5% discount and a 70% discount. But it's really the 5% discount that's in play, because the 5% opens the door for more of this backroom negotiations on rebates. And by the way, none of that benefits the patient.
Right.
The rebates always benefit, the manufacturer and the pharmacy benefit managers and the insurers. And
yeah, so that's number one. And number two, if Medicare really cared about our patients, they would approve coverage for sub-Q therapy, which they don't. So a lot of our patients end up in the donut hole at 6,000 or 7,000, which is about what your Dallas Maverick owner is going to be selling biosimilar adalimumab for. So if you're buying directly from Mark Cuban, I think he's going to charge $7,000 for Humira biosimilar, but that's like the same price as the donut hole. So
I want to say it was either $577 or $700 a month through the Mark Cuban pharmacy, but you're right, it's about $7,000 a year.
It's the donut hole. And for a lot of patients, if they get coverage by their insurance company, they don't really care about it. I mean, they're still, they're going to get copay assistance from their originator, etc. So the biosimilar world, very disappointing, the pricing, what's occurring, but we'll see.
Okay. So this next report is on one of my pet topics, and that is difficult to treat RA, D2T-RA. It comes from Arthritis Research and Therapy, a Korean biologics registry of 2,300 RA patients starting either a biologic or targeted synthetic. And they just looked at those people and then characterized how many and what kind of patient it was that had D2T-RA. It was basically 12%, which falls in line with about 4 other sort of population-based or cohort-based reports of 10 to 12% as the overall number of patients who meet the EULAR definition of D2T-RA. And they said it was associated with a lower age, longer disease duration, lower patient globals, higher DAS scores, higher RAPID-3 scores, less rheumatoid factor positivity, and these people were less likely to receive methotrexate, sulfasalazine, and leflunomide. Again, not in itself overly interesting. I like the number, and I bring it up, one, to get your comment, but also to let the audience know that next week, early next week, I'm putting out a paper about what to do in multi-drug failures, where I sent this request to about 50 of our peers. I got back a lot of responses from some major people on their approach to multi-drug failures in RA. And I'm just going to begin with a quote from Ted Pincus, who began his by saying, in my experience, all multi-drug failures in RA are the result of joint damage and or patient distress manifest as blah, 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 anxiety, fibromyalgia, whatever. So we're going to see more on this from a large number of people, but what's your take on this kind of data?
So we've looked at our registry at the Brigham, which is 1,500 patients with RA that I started in 2003 with Nancy Shattuck.
The brass registry.
That's like 20 some years now. And about 70% of our patients are on biologics and JAK inhibitors. 60% are probably on methotrexate in combination, etc. And it ends up that 60 to 70% of our patients are in low disease activity or remission, which is great. Those patients are doing great. We're not cycling, they're staying on their initial anti-TNF therapy generally. They're with methotrexate, which I think is important. We got about 20 to 25% that are in moderate disease, and we got 10% that have gotten every drug imaginable and still have high disease activity. And if I have to look at it globally, I would agree with Ted. Boy, a lot of these patients have had decades of rheumatoid arthritis. I mean, they had their disease for 20 years before we used methotrexate, for instance, or 10 years. And a lot of them are structural damage and they have pain. And I don't, to me, this is one of the great challenges. It's the patients with the high moderate RA. Because I think if you're in the moderate class, if you're closer to low disease, you're probably like them. But if you're closer to the moderate high, like on a CDI, you're more like the high disease activity. And I don't think we have drugs that necessarily target what the issue is. I think the work that's come out of the UK, looking at synovial biopsies, highlighting the importance of the fibroblast in long-standing disease is really critical. And we need therapies directed against the fibroblast, and particularly in these patients with high disease and moderate disease activity. Maybe we're using the wrong drugs, but a lot of them have such structural damage, I'm not sure it's going to make any difference. It's hard to convince pharma that we don't need another Humira.
Right.
What we need are drugs for that moderate to high disease patients that have already experienced an anti-TNF.
So Michael, referring to the RAR4 study, tocilizumab versus rituximab, great work there. On your recommendation, and I told our audience this in the past, look at RheumNow Live 2023 and a great lecture by one of your colleagues, Mike Brenner. Oh my God, what an eye-opening lecture, especially about fibroblasts and what we're not doing and what we need to target. So you're falling in line with a lot of the thinking that really we need to dominate if we're really do better with RA. So
yeah, a fibroblast inhibitor, there are theoretical concerns about wound healing, etc. But I think that's a cell line that we, for years, decades, forgot. And we need to, people are starting again now to talk about. Mike had developed this anti-cadherin 11, which we thought would target the fibroblasts. It wasn't terribly effective, and Roche did one of the really novel trials where they combined it with anti-TNF therapy. It unfortunately didn't work, but the concept of combining it with other treatments makes a lot of sense.
Certainly. I have to go back to something you said a few minutes ago, and that was in the brass registry, you're getting high-end responses out of 60% of your patients. I love it when I find out how wrong I am, because I surveyed rheumatologists about maybe 10 years ago and asked them, how often do you achieve either remission or low disease activity state in your RA patients? The numbers I got back, I thought were laughable. 80%, the low disease activity state, 80% said they get a low disease activity state, and 60% of their patients get remission. And I said, based on the published data and whatnot, that's impossible, but your numbers are actually kind of close to that. Why are we doing better now in real practice compared to what some of the data that's in the trials?
Number one, we're starting people on treatment as soon as they walk in the door. And I think we're seeing people, my own bias is, we're seeing people with earlier disease. And we have like hundreds of patients right now on a waiting list to come in to see us. And this is not unique for the Brigham, it's everywhere. We've got this log jam of patients trying to get in to see the rheumatologist. I mean, Jack, we need to figure out better ways to get these people serviced. And, rheumatologists don't have time. I mean, we're booked up. And so earlier intervention, we're going right to methotrexate. We're not wasting time with a lot of other drugs. And then I think many of us are going rapidly to another drug. I mean, Ed Keystone reported this a decade ago, looking at some of the Humira data sets, that if you waited more than 6 months to add anti-TNF, for instance, to methotrexate over the course of 10 years, you never caught up radiographically and functionally either. So, I mean, you can't wait a year to start another drug. I mean, so starting a drug on top of methotrexate ought to be an earlier rather than a later decision. And ultimately, I talked about this on Tuesday night or in my podcast, in my whatever it was, podcast or something, Zoom call. I talked about the importance of keeping people, if they can tolerate, on methotrexate if they're on a biologic. Because if you're stopping their methotrexate because you don't want to be on methotrexate and they're on adalimumab, a significant percentage of those patients over time are going to get blocking antibodies and lose efficacy with the drug. So
in getting better at RA, earlier, more aggressive, maybe smarter use of drugs. A Nature Scientific Report study this past week came out from Japan. 106 RA patients starting first-line biologics, either abatacept, tocilizumab, or a TNF inhibitor. Of the 106, about a third of the patients started ABA. And they did HLA typing, class 2 HLA typing on all the patients, and they showed for only abatacept that if you had this related haplotype related to RA 0405, you had a much higher high-end response, SDI50 of 71% if you were 0405 positive, but if you were DR beta 1 0405 negative or had 0101, 0401, that you didn't achieve those 71% responses, it was more like 30%. So I like this data because I'm always trying to figure out how can I do better than flipping a coin on my next, especially second line choice. Do you think we'll ever get around to using this kind of data in treating patients?
well, I hope so. BMS is doing a study now looking at patients with the shared epitope that are CCP antibody positive to see if you have both, whether you have a better response with ABA versus an anti-TNF treatment. I mean, that's kind of, I don't want to say precision medicine, but it's about as good as we're going to, for right now.
Right.
You may remember this, that like 30 years ago, Gabriel Panay, when we actually used gold salt therapy, Gabe was first reported out an HLA association with gold-induced nephrotic syndrome. And we did a subsequent study at the Brigham as one of my first research work with David Glass and John Coblin. We reported out an association of gold-induced thrombocytopenia with DR3, and we reported that patients, I think that were DR2 positive or some, actually had the best response on gold. And that kind of like died after a while because we went to other drugs. But I do think there's going to be genetic reasons why people have a better response on drug therapy.
I have to tell an anecdote that I think is incredibly funny, and I'm probably going to get into trouble for this, but it's my podcast, what I care. So again, 25 years ago, ACR meeting, plenary session, one of the plenary session talks was an HLA DQ association with breast implant associated arthritis. And, great presentation, number of people run to the microphone. Bev Rahan gets up and asks the question, great presentation, thank you for that. How do we know HLA-DQ6 isn't associated with women who have small breasts? And of course the crowd went crazy and whatnot. So some of the fault in limited studies and trying to make these associations, but I think that the trial you talked about is a follow-up to the AMPLE trial, adalimumab versus abatacept, but now trying to go after this typing, probably going to be powered for a good message. We'll wait and see what that study may show. This next report is our last one I wanted to cover, and this is the ability of machine learning to help diagnose arthritis earlier. This comes from the journal we don't read, Journal of Translational Autoimmunity. I didn't know existed, but somehow I found the report. It's an interesting report, and it basically uses a tool, a machine learning tool, that looks at 3 years of EMR data to find the clues to better diagnose, earlier diagnose psoriatic arthritis. So over a 12-year period, they looked at two populations, a general practice population and a psoriasis population. These were kind of large, thousands of patients. And they ultimately showed that using this tool, they were able to diagnose psoriatic arthritis 1 to 4 months earlier with a specificity of over 91%. And at 1 month before the diagnosis, their sensitivity was around 50%. And at 4 months before, the sensitivity was, I think, 30% or so. But the point is that, we do have a significant problem of A, referral, and B, earlier identification, and getting these people in on the right therapy. Do you think this could be an advance that might end up in your hospital system or mine?
Well, I don't know, but talk about psoriasis, and I don't mean to besmirch my dermatology colleagues, but I'm not sure many of them are experts in figuring out whether someone's got active arthritis or not.
Right.
So anything we can do to get patients with psoriasis to the rheumatologist for early psoriatic arthritis is only going to be an advance for patients. I mean, one of the things, and maybe this already happened, because you could ask Artie or some of your other colleagues, is are we seeing lower rates of development of psoriatic arthritis in patients that start effective therapy for psoriasis very early? In other words, if you get on an anti-TNF that's at the bottom of the line, an IL-17 inhibitor or 23 inhibitor, and have no skin disease now, are you going to get psoriatic arthritis? I mean, I don't know the answer to that.
There's a number of reports that support that contention, but the experts in the field, Alexis Ogden and Chris Richardson and others, say there's a lot of bias in that, channeling bias and confounding. So it's hard to know that treating preclinical psoriatic arthritis, aka psoriasis, with biologics prevents that. It's an interesting concept, but I think you're right that dermatology is going to love this tool because it relieves them of a lot of responsibility, and they're struggling, what can we use to better identify people and refer them to rheumatologists? So I think that they would take this gladly into their practice.
I think it'd be very helpful for patients. How's that? Yeah. And that's our goal, is to get patients seen earlier and get it treated sooner.
The last thing I wanted to throw at you was something we came up with when we were doing our planning for this month. We said, you said we really need to get some commentary on the steroid issue. The EULAR's got a view, the ACR's got a view, they're really quite different. So we got great people to contribute a 3-part video, 14 minutes long. It's under Therapeutic Update on the website. It's called Steroids NRA. It's a perspective piece with Robert Landaway explaining the EULAR position on why they are much more permissive about starting steroids and acknowledging the merits of short-term, low-dose steroids, acknowledging that most of you are going to stop it at some point anyway, which is in contrast to the ACR view, which is presented by Brian Englund, who does a fabulous job basically saying, who are we kidding? There's side effects here. There's issues here. And we're not that good at getting people off the steroids. And the benefits we're all talking about are kind of soft. They get better faster. They feel better sooner, but the toxicities are real, albeit small, they're real. And then we have the deciding vote being cast by Down Under from Peter Nash, who gives a totally different view, but he kind of sides with that you should use them, but that basically saying, I guess, that the EULAR people are right, but I have an American or ACR worry. So were you not on the?
Yeah, I was on the committee. Yeah. So I agree with Brian, actually. Even though, look, there's not anyone who practices rheumatology that would say they don't use steroids. So I'll be very candid. I do use steroids in someone who's functionally impaired when they walk in the office, that I don't have the ability to start them on a really rapid onset drug. I mean, methotrexate works quick, but it ain't that quick.
Right.
And we're not going to use a JAK inhibitor because of the label, and we can't get to a biologic until you get a trial with methotrexate. So, and someone for 6 to 8 weeks, they're not going to be able to function. We would use a little bit of prednisone. But ultimately, I just don't think every patient with RA should get exposed to steroids, because a lot of these people, I think, never get off their steroids. And any dose of prednisone is toxic. And if you can't admit that, then you're not following these patients. It's not just, you know, metabolic syndrome. What we see are patients who have skin fragility issues, that can't wear a short sleeve shirt, that bruising everywhere, the hyperpigmented, the patients that are getting cataracts and osteoporosis, increased risk of cardiovascular disease. And Dan Solomon has shown now in a number of studies that essentially any dose of prednisone is associated with a higher risk of infection. So that's the reason. If I knew that 100% of the people that we started on prednisone, we get off steroids in a couple months, I wouldn't have this problem. But I don't see that in my practice. I mean, some of these people are still on prednisone, maybe because our other drugs aren't that great. But you know, I'd rather not use steroids if I could avoid it. And I personally, I think if we give the statement out, you can use steroids, then a lot of people are going to go on steroids that probably don't need them.
Yeah.
And low dose is better. I mean, so
I'm right with you in my practice and also my worries. I tell everybody steroids are acutely wonderful, chronically dangerous, and that they must be written with an unnegotiable expiration date, meaning I'm only giving you, 56 days of prednisone. There will be no more after that, something like along those lines, so that decision making is already established.
But I'm sure, Jack, you have patients who you say that to, that you look 3 years out, they're on 3 or 4 milligrams of prednisone because you can't get them off the steroids.
And I tell them, you're making me look bad. You're making me look really bad. But yeah, that's the struggle. And the problem is patients believe that the drug that makes me feel great is got to be the best drug for me, when in fact they don't listen to you when you say it's actually no longer the best drug for you. So Michael, this was absolutely wonderful and enlightening. Thank you so much for all your hard work and being on this podcast. I want to remind the audience, next week on Tuesday Night Rheumatology, we got a great panel discussion on DMARD choices and changes. It's me, Artie Kavanaugh, Alan Matsumoto, and Madeline Feldman. It's going to be fun. Be there. Mike, thanks again.
Thank you. Bye, Jack.